Good afternoon, everyone, and welcome to our e-forum addressing anti-Black racism in healthcare. A few preliminary comments before we get started. If possible, please close other running applications to improve connection on today's platform. If you are experiencing technical issues, we recommend that you exit and log back into today's session. And if that does not address the issue, please contact us at dei@castlepo.com and we will try to assist. Today's session will be recorded and posted on Castlepo's website under our recently revised DEI webpage under the section Diversity, Equity, and Inclusion eForum Series. Today's presentation is intended for educational purposes. And so viewing this session can be counted towards your self-assessment tool learning goals. And we have also saved time today at the end of the session for questions. So please feel free to enter your questions in the box you should see on your screen. Questions will be accepted throughout today's presentation. And so we will be monitoring, and there's no need to wait until the end of the session to start answering your questions or start asking your questions. We will try to answer as many questions as possible. And as a reminder, we are here to listen and learn. And so we ask that your questions and comments be open-minded. I will offer a content warning. Some of the material today may be upsetting or difficult to hear. We encourage you to take time for self-care when needed. You can return to the recording at a later time, and Castlepo staff are always available to answer any follow-up questions you may have. So with those preliminary items covered, I'm very excited to welcome today's speaker, Dr. Trudy McFarlane. Dr. McFarlane is a family physician, GP, and psychotherapist, as well as a medical consultant and an assistant clinical professor, and serves as the Black Health Lead and Special Advisor to the Dean at the Toronto Metropolitan University School of Medicine. Dr. McFarlane is involved with all facets of the School of Medicine, providing leadership within administration and curriculum. She serves as a regional representative of the Black Physicians of Canada, as a co-chair and founder of the Black Physicians of Nova Scotia, and a member and regional physician lead of the Black Physicians Association of Ontario. Passionate about advocacy, mentorship, diverse representation and leadership, and health equity for racialized communities, Dr. McFarlane joins us today to discuss addressing anti-Black racism in healthcare. With that very truncated introduction, Dr. McFarlane, I turn it over to you.
Thank you so much, Priya. Good afternoon, everyone. It is such a pleasure and privilege to be here with you all today. Thank you for joining and committing to engaging in this session. Anti-Black racism is a public health crisis, and which is why it's so important for us to address. So the intent of our time together is to gain insights into what anti-Black racism is, how it manifests within our healthcare system, and what we can do to dismantle it. Next slide, please. Why don't we start with the land acknowledgement as well as an African ancestral acknowledgement. I do want to just caution, my voice is in and out today, so please be gracious and forgive me. I may need to take some pauses to take a drink of water or clear my throat. The land acknowledgement that I will be sharing today was developed by my colleague, Dr. Jamaica Cass, the Indigenous Health Lead at the Toronto Metropolitan University School of Medicine. And often you'll hear me maybe abbreviate that as TMU School of Medicine. So I'm situated in Brampton, so I know that some of us are near and far, so please reflect on the lands for which you work or live. So Brampton and its surrounding area, the Peel region, are part of the treaty lands of the Mississaugas of the Credit. We acknowledge that these lands are also the shared space of the Anishinaabeg, Huron-Wendat, Haudenosaunee, Ojibwe Chippewa, and Métis peoples. We honor the Indigenous peoples who cared for this land for thousands of years before us and commit to valuing the two-row wampum. This living treaty represents settlers and Indigenous peoples moving forward together in parallel, respecting each other's ways of being, knowing, and doing. We honor the Dish with One Spoon Treaty And in this spirit, we strive to treat the land and people of our community with mutual respect, taking only what we need and sharing what is available to ensure sustainability for those that follow us. Now, as we remember our ancestors, forcibly displanted African peoples trafficked into Turtle Island as a result of the transatlantic slave trade and the histories and legacies of colonialism and neocolonialism, which continue to impact African peoples and the descendants of the Black diaspora across the world. We recognize that racial colonial violence harms Black, Afro-Indigenous, and Indigenous peoples through both common and distinct logics and actions. We recognize our responsibility and obligations as African peoples to be good guests on this land, and we offer thanks to our elders and communities from whom we learn. May your wisdom inform our actions towards a more just future. And this was also authored by the Black Health Education Collaborative. I always find it's good practice to kind of do a personal reflection. And this session on anti-Black racism is timely as we move from August, which was Emancipation Month, and represents the abolition of enslavement. And we're moving into September, the beginning of fall and a season of harvest. This time of transition reminds me of the histories, the strength, the resilience, the struggles that the land has witnessed through the journey of our ancestors, a journey that continues today. I have to admit, I feel a profound sense of responsibility to carry forward this fight, but I also invite you to embrace this journey as your own. Dismantling anti-Black racism is a collective responsibility, and together we can plant seeds for a future where justice, equity, and respect for all peoples is not just a vision, but a true reality we will live one day. Like the harvest that follows planting, the work we do today really is an investment in the flourishing of future generations. I'd also like to share a guiding principle or framework that I find useful and applicable to addressing anti-Black racism in healthcare, and that is Ubuntu. This is an African philosophy that translates to I am because you are. This considers the humanity and interconnectedness of us all. When we apply Ubuntu to healthcare, it reminds us of the experiences of Black patients and healthcare professionals that cannot be separated from the overall health of our society. If Black communities are disproportionately harmed by the healthcare system, we all suffer a collective moral and social cost. It's important to reflect and ground ourselves for these discussions, acknowledging that some of the content we'll be discussing can be difficult, disturbing, and for some, uncomfortable. Next slide, please. During this session, we aim to maybe create a brave space. I like to kind of just do a general overview of ways of engaging. And so this is a space where we can speak truthfully and listen deeply, and be willing to challenge conversations that can be difficult, because we're addressing difficult truths. We need to acknowledge the realities of anti-Black racism, even when it's uncomfortable. So in this space and during our time here together, bravery is being vulnerable and open to this growth. I encourage you to stay engaged, inviting you to be present and attentive, actively listening and being thoughtful, and when appropriate, asking questions and sharing your experiences. And I think, as Priya already alluded to, openness is important and key to learning and unlearning. So let's approach today's session with an open heart and mind. This allows us to challenge our own assumptions, and allows us to hear different perspectives and consider new ways of thinking about anti-Black racism. Respect is essential for any meaningful dialogue, so let's ensure our words, our attitudes, and actions reflect a deep respect for the experiences and perspectives shared in this space today. Discomfort is inevitable, so when confronting hard truths, let's just lean into it. It's often a sign of growth, and we all have room to grow, and it's necessary really for deep understanding and change. And finally, I'd say anti-Black racism is a complex and ongoing issue that will not be solved in a single session, let alone today. However, it does highlight the need for ongoing reflection and action. So non-closure is a part of this journey. Next slide, please. Okay, so as we're preparing to get into things, let's just get grounded to ensure we are ready and bringing our best selves forward. I recognize that for many of you, this session might be taking place during your lunch hour, which is right in the middle of your busy day. And it can sometimes be challenging to decompress and not have your mind on the things that are waiting for you after this session, speaking from personal experience. So to help us engage, I want to invite you to ensure you're in a quiet space with as few distractions as possible. Take a moment to adjust your body, finding a comfortable and relaxed position. And if you so choose, I welcome you to close your eyes for this next little bit, where you'll take a few deep breaths in. Let the air fill your lungs and then expand throughout your body. And as you exhale, release any tension you might feel. So that might be the tightness in your shoulders, the clenching of the jaw, and any other areas of stress that you might have. If there are thoughts and tasks that might be pulling your attention away, take a moment to acknowledge them. It happens. But I ask that you gently release them and set them aside for the time being. I want you to allow yourself to be present here. Commit to being open, actively listen. This is a time for you. It's a time for us to connect, reflect, and grow together. So let's make the most of it. Next slide, please. So now let's focus on what we aim to achieve together today. So the key objectives include examining the historical context of anti-Black racism and understanding the legacy of past injustices. And so although much progress has been made, I would say there's still much work that still needs to be done. It's important to recognize what anti-Black racism is and how it manifests and persists today. And finally, we would want to turn our knowledge and reflection into action to address and combat anti-Black racism within our sphere of influence and contribute to positive change. Next slide, please. All right, so I find the practice of acknowledging my positionality and defining the language we'll be using is incredibly important to understanding the perspectives that I bring and to ensure we're all on the same page. So as a Black cisgendered female, able-bodied physician and an advocate for health equity, my experience and background shape how I approach the topic of anti-Black racism in healthcare. My work is informed by both lived experience and professional expertise, and it's important for you to know that I speak from a place of both personal commitment and professional responsibility. So just as important as it is to share parts of who I am, it's important to clarify who I am not. As someone who leads health equity work, I've come to realize that some folks may come to perceive me as an equity police, a dictator of sorts, or sometimes someone who is all-knowing or thinks they're all-knowing. And I assure you, I am none of those things. In fact, I see myself as a lifelong learner with plenty of room to grow and evolve. Quite honestly, if we ever find ourselves at a place where we don't have room for growth, we might need to do a pulse check, yeah? All jokes aside, I approach this work with humility, with the appreciation that each day and each interaction brings with them lessons and opportunities. Positionality matters, especially in conversations about race, and I invite you to reflect on your own position, your privileges, and experiences as we move through this session together. Next slide, please. Now, okay, some common knowledge. I know that CASAPO has done much education and work with respect to EDIA and anti-racism. However, let's just briefly define some common terms to make sure we have a shared understanding throughout. So diversity really refers to the presence of differences within a group. Inclusion welcomes and makes space for that diversity, creating environments where all people feel valued and respected regardless of their background. An anecdote that I really like with respects to inclusion that has really stuck with me is it's not just about being invited to the party. It's about being asked to dance, to contribute, and to maybe even help shape that party, yeah? Intersectionality is a concept coined by Kimberly Crenshaw to explain how different aspects of our identity, such as race, gender, class, etc., overlap and shape individual experiences, especially those in relation to discrimination. Really, everyone has their own unique experiences of discrimination and privilege. And so if we go to the next slide, please, just revisiting my own positionality statement. I've shared about maybe 10 characteristics here, and nearly half of those, such as race, gender, faith, and heritage, may be considered points of discrimination or disadvantage within various systems. And in some cases, those that offer or would be considered advantageous, that might add power or privilege, such as being Canadian born, being a physician, being a leader, are sometimes not protective in certain spaces and are overshadowed by my more visible qualities. Next slide, please. Equity and equality are often used synonymously, but they certainly are not the same. So just wanting to clarify that equality means treating everyone exactly the same, providing the same resources, which assumes that everyone benefits from the same supports in the same way. However, in healthcare, I know we know this, that one size does not fit all, and that approach does not serve all our patients and clients. Equity, on the other hand, recognizes that people have different starting points and positions, and it acknowledges that varying levels of support may be required to achieve the same outcome or goal, yeah? The aim of equity is to create a more just and inclusive environment where everyone has opportunities to reach their full potential. So for our purposes today, equity means we must consider the specific challenges that Black patients face and tailor our interventions to really address those needs. So from the image that is shared here, again, equality, giving everyone the same thing doesn't always work. And then in the next picture with equity, they attempted to show different interventions to achieve the same outcome of being able to see. But what bothers me about this image is that it still presents a barrier. And I think the point of equity is so that we remove barriers. So I much prefer the next slide, please. And so with this image, as we can see with equality, everyone is given the same thing, and we see the varied challenges for each individual because it's not right sized for them. And so we even see how individuals are unable to access or utilize the resource or intervention. Whereas with equity, the resource is tailored to and right size for each individual, and the barriers are minimized or removed so that they get the specific support that they need to succeed. So I love that. Keep that in mind. Okay, next slide, please. All right, and so let's get into a little bit about race. So race itself is a social construct used to characterize and differentiate people based on physical characteristics such as skin color, facial features, and hair texture. There's actually no scientific or biological basis for these categories. However, they have been used for a long time to maintain hierarchies of power and privilege. And so in early times yet, there was thought to be biological differences with Black people in comparison to white folks, but studies have shown that that is not the case. One such study is genetic variation, classification, and race. And this highlights that there is more genetic variation within racial and ethnic groups than there are between them or across between different races. And so race itself is not a useful biological concept in understanding human diversity. Really, these differences are based on social class system. Racism is the belief or ideology that one race is superior to others, leading to discrimination, prejudice, and the antagonism against individuals or groups based on their race or ethnicity. So this can manifest individually, whether that's internalized by individuals, believing the negative narrative or stereotypes of their community, or this can be interpersonal, so between individuals. And of course, I think, as we all know, these kind of persist and are deeply rooted in institutions, the system, and structurally. Anti-Black racism is a specific form of racism targeted towards Black people. It is a term that encompasses attitudes, beliefs, prejudice, stereotyping, and discrimination directed at people of Black African descent. This form of racism is deeply rooted in the history of enslavement and colonization, and is embedded in policies and practices that devalue and marginalize Black individuals and communities. In healthcare, this translates to unequal access, disproportionate negative health outcomes, and underrepresentation of Black healthcare professionals. So this term was first coined by Dr. Akua Benjamin, so that she is a professor emeritus at TMU, so Toronto Metropolitan University. And this term was introduced to highlight the unique and distinct and pervasive nature of racism faced by Black individuals, and really requires specific recognition and tailoring of interventions and solutions. Another way that it's put or has been defined by Charlene Carruthers is that it is a system of beliefs, practices that attack, erode, and limit the humanity of Black people. Next slide, please. So anti-racism is a broad commitment to actively opposing racism in all its forms, and it really is taking a proactive approach. This would include addressing or challenging policies, procedures, systems that sustain inequities and power imbalances. It recognizes the existence of racism, actively seeks to identify, reduce, and remove the racially inequitable outcomes and power imbalances between groups and the structures that sustain these inequities. This is where we ultimately want to end up, right? So now that we have established these foundational concepts, it's crucial to understand why we need to specifically address anti-Black racism, especially within healthcare. And so, you know, I think outside of being anti-racist, we also want to name specific forms of racism. And so specifically, anti-Black racism must be recognized and tackled distinctly rather than being subsumed under, you know, broader umbrellas of equity, diversity, inclusion, accessibility, and anti-racism. And so to achieve true health equity, we must confront and dismantle the systemic and structural racism that uniquely affects Black individuals and communities. Okay, next slide, please. So anti-Black racism is pervasive, it's deeply rooted, and it shapes the experiences of Black people in many aspects of life, including and not limited to healthcare. Anti-Black racism is embedded in policies, practices, institutions throughout Canada and beyond. And so to understand anti-Black racism today, we need to look at the historical roots. And so Dr. Martin Luther King Jr. said, of all the forms of inequality, injustice in health is the most shocking and inhumane. So the exclusion, exploitation, and dehumanization of Black people have shaped how healthcare system functions today, which has contributed to long-standing disparities within the Black community. The history of anti-Black racism in healthcare can be traced back to colonial era, when Black people were enslaved and subjected to inhumane treatment. Their bodies were often used for medical experimentation without consent, laying the groundwork for a legacy of mistrust in the healthcare system. Next slide, please. So let's walk through some of the key moments in history that demonstrate the trajectory of anti-Black racism. And I know that for some folks, history can be challenging to take in, and I ask you to just stick with me. It's important to go through this, as it hasn't been available in early education of the full history of this country. And that just highlights the history of Black peoples in Canada as one of erasure, exclusion, and exploitation, despite great contribution and loyalty to this country. And so dating back as early as 1608, Matthew da Costa was the first Black person to step foot in Canada. He was a free man, and he was hired as a translator of many languages. That would include French, Dutch, Portuguese, and later Mi'kmaq language, and others. So he was quite talented. 20 years later, slavery becomes official in Canada with the arrival of the first enslaved African boy, Olivier Lejeune. This speaks also, so we highlight the first enslaved individual was a young boy. So this really speaks to the separation and the breakup of the Black family structure, as families were often sold to slaveholders independently. In 1834, specifically August 1st, this marks the abolition of slavery in Canada, which is now recognized as Emancipation Day, which later transformed to August being Emancipation Month. But what followed from that was the era of segregation. I'm going to highlight a few introductions of the firsts in healthcare, including medicine and other healthcare professionals. And so in 1885, Dr. Anderson Abbott became the first Black physician. And then 20 years later, we see the first Black female Canadian physician, Dr. Sophia Jones, at that time. In 1910, the Immigration Act was employed, and this was designed to keep Black people out of Canada for fear of them overflooding the country following freedom, especially those kind of migrating from the United States. In 1918, Queen's University banned Black students from their medical program. This ban lasted until about 1965, but it remained on the books until 2018. When this was employed, many of the other medical schools followed suit. And so, we see decades of harm to Black Canadians being able to enter this profession, which speaks to the underrepresentation that we see today. In 1930, Margaret L. Clark became one of Canada's first speech language pathologists, and she helped lay the groundwork for what has become recognized as an essential healthcare profession. In 1945, Bernice Redmond became the first Black nurse to practice in Canada after being denied entry into a Canadian program. She went to study nursing in the United States and then returned back home to practice. In 1946, Viola Desmond, who you may recognize from the $10 bill, she challenged segregation at a theater in Nova Scotia years before Rosa Parks, who in the States was well known for her refusal of giving up her seat in a segregated bus. Viola Desmond was arrested and convicted, and posthumously she was pardoned in 2010. And it was in 2018 that she became the first Canadian woman to be featured independently on a banknote. And so I wanted to also, I tried to search for contributions or early Black audiologists, and Dr. Leo Mayer was a name that came up. And so not much detail was found about his contributions or his practice, but I know it took place for between 1950s and the 1960s, and he was definitely a pioneer within the field. And then I wanted to note the West Indian domestic scheme that took place between 1955 and 1967. And so this is where Caribbean women were recruited to Canada to work as domestic servants, and this coincided with the growing demand for help as Canadian women were entering the workforce. The Caribbean women were paid much less for the same or even more work than their European counterparts. And specifically for Caribbean women, they were required to be single to be able to be recruited. And this was a means to prevent Black men from entering the country on sponsorship. So, and then furthermore, although there was a great demand and the need for domestic help was still needed, the program was discontinued due to backlash towards the increase in Black migration to Canada. So I hope from this you can see that Black people have had a long history here in Canada for over 400 years. Today, Black Canadians make up 1.2 million of the population, which is about 3.5% of the nation's population, with over 50% of them living here in Ontario and still growing. Next slide, please. So the lasting consequences of this history that was just shared has really affected nearly every aspect of life, from health and economic status to the family and social structures. So I just identified some key areas, but really you can find the impact of racism in every aspect of life. So with respects to health disparities, Black individuals experience disproportionate rates of chronic illnesses like diabetes, hypertension, and heart disease. Part of this is due to race correction in medical algorithms, which further exacerbate those inequities. So race correction, if you haven't heard of it before, refers to a practice of adjusting or modifying medical algorithms or diagnostic tests or treatment decision trees based on a patient's race or ethnicity. Some examples would include pulmonary function and eGFR, which is a measure of kidney function. This approach has often been based on the assumption that there are biological or genetic differences between racial groups, which again, as I've said earlier, this is not factual. It has been increasingly criticized as a result, as it reinforces racial biases and really doesn't take into account individual circumstances or social determinants of health. Fortunately, there's been some significant progress in this work where we're removing race correction from current day practices. And so an example of this may be blood work. So if you looked at blood work, a few years back or even up until last year, you would see that for eGFR, so for renal function, they would have different measures for Black individuals. And so labs have now communicated that they are no longer using that. And so newer blood work demonstrates and distinctly highlights this change. So this was a huge step towards a more equitable healthcare system. I would say in terms of criminalization and dehumanization, historically, the perception of Black individuals as being dangerous has really led to over-policing and discrimination in healthcare. And some of this comes from just the mere fact that they were trying to escape inhumane circumstances and environments. And it was actually pathologized as a mental health disorder that one would want to escape or flee. And so we see how that kind of plays out in present day. Economic exploitation. So the unpaid, of course, being enslaved was the unpaid labor of Black individuals, and this contributed significantly to the economic wealth of the slaveholders and this country. And like I said, exclusion from economic opportunities has really been limiting for Black communities and has impacted access to education, employment, and even good quality healthcare at times. And 4, disruption of family structures. So again, as I mentioned before, immigration policies and slavery really disrupted the Black family structure and really affected the mental health and social stabilities of families. And we can sometimes still see that today. All of these historical harms would be contributed to what we now phrase as race-based traumatic stress, which really encompasses the psychological, emotional, and physical harm resulting from racial discrimination and systemic oppression. This form of trauma can lead to a range of negative health outcomes, including chronic stress, mental health issues, physical illnesses, ultimately contributing for some to a shorter lifespan and reduced quality of life for Black communities. The cumulative impact of these harms highlights the urgent need for systemic change to address and mitigate the long-term effects of racism on health and well-being. Next slide, please. So historically, Black individuals have been disproportionately subjected to unethical medical experimentation. And I've shared a few here. One of those being J. Marion Sims, who performed gynecological surgeries on enslaved Black women without anesthesia in the 1840s. And then there's the Tuskegee syphilis study, which ran for approximately 40 years, from 1932 to 72. And this studied Black men with syphilis, and they were left untreated for decades to study the disease's progression even after treatment for it was available. So of course, you can imagine how, again, that plays out in the mistructs of folks today. Henrietta Lacks had cervical cancer, and her cells, which they termed HeLa cells, were taken without her consent and they were used for countless medical advancements with no compensation for the family. And I think it wasn't until a year or two ago that the family received an apology about this. And then for some Canadian context, the Halifax explosion that took place in 1917, Black survivors of this event were subjected to unethical medical experiments based on the belief that their bodies reacted differently to trauma. Next slide, please. Now, we'll shift to the present day. So the legacy of anti-Black racism in healthcare has not gone away. It's embedded in how healthcare is practiced even till today. The upcoming slides will explore some specific examples of these disparities and biases. But first, the most basic of human rights is the right to health. Yet, for Black people, that right is often overshadowed by the systemic underestimation and dismissal of our pain. And this is from Dr. Uche Blackstock, the founder of Advancing Health Equity and the author of A Legacy, a Black physician who reckons with racism in medicine. Next slide, please. So there are huge racial disparities in how pain is managed within Black communities. And so Black patients frequently are undertreated for pain. And some personal examples include a male relative of mine who went to the ER with severe abdominal pain and vomiting, feeling gravely unwell. He was dismissed and discharged with simple painkillers. No imaging was done, no regard for his experience. Later, the same day, he went to a different hospital and was discovered to have had acute appendicitis, which is a surgical case and required a surgical intervention, same day. This experience is not uncommon. Another presentation that is often common amongst Black patients is a pain crisis secondary to sickle cell disease, which disproportionately affects Black people. They often receive inadequate pain management, and if it's not overall well managed, this can lead to death. The Journal of Pain Research in 2020 found that Black patients are 40% less likely to receive the same pain medication strength as their white counterparts for similar conditions. I remember an experience professionally that I had of a female patient who underwent a gynecological procedure. And usually for this procedure, patients would be prescribed a pain pump. So once you get out of surgery, you have an IV for which you can administer pain medication as needed. But there was a trend where oftentimes you would find that Black women were not provided with the pain pump and would be writhing in pain sometimes when I'd examined them. And so this, again, is a testament to the impact of anti-Black racism on clinical care and poor pain management. A study by Hoffman in 2016 and his team found that medical trainees still believe in false biological differences between Black and white patients, which affects how pain is treated. So again, this goes back to the thoughts and ideas folks have and how that pans out and how they treat patients. And so some of the stereotypes or ideas that people have is that, Black people are strong, they can endure pain, and sometimes they let them. I don't know why that would be okay. Other times they think Black people have thick skin, so they're not as sensitive to pain, and so their pain is not believed. And so really keep this in mind with respects to how there's differential treatment with similar conditions in healthcare. Next slide, please. We also see disparities in maternal fetal health. Now, the CDC demonstrates that Black women are 3 times more likely to die from pregnancy-related causes. And you can see some of the numbers over the years. Unfortunately, race-based data isn't widely collected in Canada, but it's starting to change. And so I do know that they looked at some preterm births and compared Canadian populations to US populations. And what they found was that similarly, preterm births have a higher proportion in Black communities. And that same trend was similar in Canada as it was in the US. And it's likely that we would see the same here. And so much since the pandemic, I would say, which highlighted racial disparities in not only the disease, but how it was managed, is now spearheading or is now contributing to research looking at obtaining race-based data so that we can address some of those disparities. Next slide, please. Okay, and just the Spotlight case, I think just because it's common and Serena Williams was really vocal about it, where even her, despite her wealth and her status, experienced severe complications after childbirth, and had to really heavily advocate for her own care because she was being ignored. So she, had symptoms of shortness of breath, altered level of consciousness, increased pain, which ultimately was identified as a pulmonary embolism. The background story is she had had this experience before. And so when she was experiencing these symptoms, she shared with her healthcare team that she was concerned that it was happening again. And she was dismissed and dismissed and dismissed until she really, really had to push, and eventually someone listened and did the imaging that was necessary to diagnose her appropriately and then manage her accordingly. But some of the similarities are, that she wasn't believed. And a personal practice of mine is that I believe patients are the experts of their own bodies and know when something is different or has changed. And so for Black patients, their concerns or requests are often dismissed or downplayed or downright ignored. And we also see here that class and status are not protective, right? Ultimately, the manifestation of anti-Black racism is no respecter of persons. Next slide, please. And so in lieu of Canadian data that I have readily available, I wanted to share sentiments of an Ontarian about her maternal experience from Amanda Paris's documentary, Standard of Care. I get chills every time I see this, so just a warning that it might be difficult to hear and watch.
I was in so much pain because I'd already been in pain for 12, 13 hours at this point, and I had requested an epidural. So I got the epidural, everything was going swimmingly. I wasn't in pain anymore, I was fine. But somewhere around 2 o'clock in the morning, I started feeling the things again. I started feeling my contractions. And so I was like, guys, I don't know if the epidural is working anymore. Dismissed. like the doctor team was just kind of like, that doesn't happen. This fear washed over me, right? I'm in pain. This is my first delivery. No one's even believing that I'm still in pain. And I'm thinking to myself, I'm like, what more can I tell you to get you to do something about this? You know, you hear these stories all the time of women telling them something's up, and they dismiss Black women pain. And we all know it's systemic, right? If we have not debunked this and we're still looking at Black women in pain and thinking they can handle it, there's something wrong. There's something innately wrong with the system.
Yeah, sorry. Just have to take a moment to pause. Sometimes that can be hard to watch, and that wasn't too long ago. And I have continued to witness this in patients and in family members. And so it's still happening today. So the hope is that collectively as healthcare providers, we can raise awareness, be mindful of our biases, and really check them. Okay, next slide, please. All right, so we also see quite a bit of disparities in mental health as well. And so Black individuals face higher levels of mental health challenges due to psychological stress that is often attributed to racism, discrimination, and socioeconomic disparities. We find that within the Black community, if they are diagnosed with a mental health disorder, it is often one that is psychotic. So that might include things like schizophrenia, rather than mood and anxiety disorders, such as depression or generalized anxiety. We also see discordant care. So Western models of mental health frequently fail to align with Afrocentric ways of knowing and healing. And so this can sometimes lead to the over-medicalization and pathologizing of Black experiences. From the Mental Health Commission of Canada, only 25% of Black Canadians feel that mental health services adequately meet their needs. As a result, Black Canadians often avoid seeking mental health services due to the lack of culturally appropriate care. So really, this highlights the importance of culturally appropriate and responsive care, which is achievable with the practice of cultural humility. Next slide, please. And so there are also racial disparities that exist in audiology and speech pathology. And so I wanted to highlight a few. Black children are frequently misdiagnosed with speech disorders due to dialect differences, where culturally appropriate speech is not recognized by Western culture. Hearing loss and otitis media, I think that's hearing loss and otitis media are often underdiagnosed in Black children. And then some studies have shown by Castle-Pass, that a lack of culturally competent tools and bias exists in standardized testing, as this is usually based on the norms of white middle class. And Black professionals tend to be underrepresented in audiology and speech pathology, whether that's in the profession or in research or in access to these services for Black communities. Next slide, please. So a lot of what we talked about really stems from a lot of the stereotypes, ideas that have stemmed from enslavement to present day, and what is the impact of that? So implicit bias really is how these biases play a role without sometimes our active acknowledgement of the same. And so again, just a few bucket items, although it can span and have impacts more broadly. Some of those include misdiagnosis. So biases may cause healthcare providers to misinterpret symptoms, especially in racial minorities and women. And for Black people, or Black patients, often their pain, as we've talked about, is underestimated, leading to misdiagnoses and conditions such as chronic pain or even cardiovascular disease coming in with chest pain and being assessed for something differently or not being taken seriously. Inadequate treatment. So we talked about also race correction. And so even with the correct diagnosis, implicit bias can affect treatment decisions. And so again, going back to undertreated pain and the study that showed that lower strength or less effective pain management is also often provided to Black patients. We saw that Black women are at higher risk of complications during pregnancy due to poor quality of care, but also just, again, due to racism and not being heard and listened to. And back to race correction, when those are employed, sometimes there's a delay in diagnosis or intervention is inappropriately matched to the severity of the disease. And then, of course, that all leads to poor health outcomes. So these disparities contribute to worse health outcomes, including higher mortality rates, lower life expectancy among marginalized populations, and the distrust fostered by this biased care leads to delayed healthcare seeking behaviors, right? And so I think this highlights that implicit bias training is essential for not only improving health equity, but improving overall outcomes and saving lives. All right, next slide, please. So let's turn to the experiences of Black health providers. There was a study, Patients, Pride, and Prejudice, exploring Black Ontarian physicians' experiences of racism and discrimination. And this was conducted in 2020, and this was the first study to explore Black Canadian physician experiences. The study surveyed Black physicians and postgraduate trainees. So another term for that is residents. And so that's once you've completed your medical education, 4 years of a medical undergrad, you go into the specialty of choice. So whether that's family medicine, general surgery, internal medicine, and so you're considered a resident at that point. And so they were included in the study as well, and they were asked for their self-reported experiences of racism. And so the findings of this were quite striking. And of course, those within the community, this is not surprising to them, but it was great to be able to really formally put this on paper so that we could really take action towards some of the things we found. And so many shared negative discrimination experiences, which may manifest as differential treatment, expectations, and racism from their peers, their superiors, and even patients. And so this might manifest as increased scrutiny, so people questioning your competence and your credentials, and where you've trained more so than they would for non-Black colleagues, sometimes asking for a lighter or non-Black physician. And can you imagine the impact of that? So those in the profession who are here to help and heal, and to be told, no, not you, because of the color of your skin. We also see a disproportionate number of college complaints for Black physicians as well. Racial microaggressions, so questioning your background, where are you really from? And so for people, I mean, certainly we have, you know, the Black community is not a monolith, right? So we have individuals that have come from elsewhere, but we do have individuals, Black individuals who are born here, like myself. And so can you imagine the constant asking of where are you from? No, where are you really from? Making you feel like a stranger in your own home. And so, you know, I really encourage folks to reflect and consider when they are asking questions. You know, you may be curious, but we want to maintain respectful curiosity. Yeah. And so what benefit or what do you gain from learning this information? And I will say, as a female Black physician, I often have to navigate answering this question or addressing this issue in a way that doesn't impact the patient-physician relationship or the colleague relationship, right? And so this can be challenging, and having to do it over and over and over again can be exhausting. We also see that there's disparities in promotion and pay. And so even despite some Black physicians having seniority in the spaces they work in, they're often overlooked for promotion, maybe not considered. And we found that sometimes pay can differ, even for the same specialty or the same amount of work. Part of that I can comment on is, so sometimes with some of the things I've shared, you have to be extra vigilant with being thorough in your explanations and being kind and open. And although everyone should be like this, I think there's an added layer for racialized physicians in that lens. So as a result of this, in some spaces, because there's an underrepresentation of Black healthcare professionals, there can be professional exclusion and isolation as a result. And in this study, they demonstrated that some folks would just internalize it, you just deal with it and move on. And can you imagine, after doing this several times, the negative psychological impact that this can have on folks? All right, and we also see that there's an impact on career location, where you choose to practice. And so oftentimes, I think this is true for most marginalized and racialized communities, but particularly true for Black physicians, as noted in this study, where they choose to work in more urban or suburban communities versus those of rural communities. You practice where there's a greater representation of your race, your ethnicity, or your faith, just recognizing the importance of having supportive community and culture with the work we do, because it's not always easy. And so having those supports, it becomes crucial. And we also see that there's a lack of mentorship and support. Again, going back to the underrepresentation of Black physicians, often they hold the burden of self-advocacy. There's challenges with navigating their career, and sometimes this can lead to career stagnation. But I do want to highlight the resilience of Black physicians and other communities as well. And so when first faced with adversity and stress, you come together, right? And so we've seen the development of affinity groups, such as the ones I am a part of, the Black Physicians of Canada, the Black Physicians Association of Ontario, and the Black Physicians of Nova Scotia. And there's many others. I mean, in medical school, there's the Black Medical Students Association as well. And so this offers a sense of belonging and community for folks. Okay, next slide, please. All right, so where do we go from here? How do we as institutions and as individuals dismantle anti-Black racism in healthcare? Next slide, please. And so our duty as healthcare providers is to listen, to believe, and to act, not to dismiss or diminish the experiences of our patients based on the color of their skin. And this was said by Dr. Nadine Burke Harris. She was the former Surgeon General of California, but she's also a proud Canadian. And so, of course, without question, continuous learning and critical self-reflection are part of the course. But let's delve into a few other details. So next slide, please. And so from a more macro level and institutional level, some of the things we can do: really ensuring comprehensive and ongoing anti-Black racism training. This includes anti-bias, anti-oppressive, and trauma-informed training along these lines as well. I would say collecting and using race-based data. So of course, this will help to identify and intervene on health disparities or disparities within organizations. But I want to kind of highlight that this is done in collaboration with and co-created with Black communities. We want to ensure equitable policies, so really creating inclusive environments for Black staff and patients to thrive. And this includes also equitable hiring practices. And so increasing representation of Black professionals, because we know that representation really does matter within the profession, but also for our patients and clients. And then this is something new, and I don't know if others are familiar with this, but I really liked what Regina Jackson kind of refers to in her book called White Women. And it talks about moving from passive allyship to becoming more active supporters or accomplices. So I would kind of liken that to partners in justice, right? So individuals who are right beside me doing the work, advocating and being actively involved. And so I think, you know, more often than not lately, I've been referring to this and really challenging people to push a little bit further past, like, you know, passive allyship to really active partnership and accomplices. All right, next slide, please. And so on an individual level, each of us can do, these are things that each of us can do in our practices and on our own. And so using racially diverse clinical tools and avoiding race-based corrections, incorporating culturally tailored intake forms, history taking and management. So this might look like providing patients and clients with the opportunity to self-ID, which allows us again to better track disparities if they exist and when they show up. Having comprehensive history taking provides insight into the social determinants of health that might impact our patients or our clients. And this way we can tailor access to service for them and be flexible with things like scheduling and being accommodating for them if we know they have specific challenges, and connecting them with resources accordingly. And ultimately getting to really know your patients and your clients. What do they value? What are their desires? What are their cultural preferences? What are their faith practices? And then really asking them how they would like for that to be incorporated in their care, right? So that might look like, you know, I'd really like my family present or involved. It might mean I want community members or involved or to work with my community organization, or even your faith community, right? And so, you know, I know this varies in terms of different practices, but how do your pastors, your rabbi, and priests engage in some of your healthcare needs as well? And so we also want to provide culturally diverse resources. So I have a picture here demonstrating an illustration by Dr. Ib of a Black fetus in a Black maternal body. Now, this illustration went viral in 2021 because it was the first of its kind in 2021. So the Black demographic is often underrepresented in medical imagery. And so this led to a global conversation about the need for more inclusive medical education materials to help reduce health disparities and really shift the culture of the Black body being an anomaly and instead normalizing it, yeah? And then partnering with and collaborating with Black community organizations to increase awareness and develop solutions to the health disparities that we see in our field. And so, you know, no one individual can do it all, and the expectation is not that you know, you do all these things and save the world, but really looking at who you can partner with, who you can collaborate with, where we can work together to really increase awareness and support for Black communities is really, really the goal. And finally, I encourage you all to just do your part, and that could manifest in various ways. But what I'm hoping to employ upon you is that you seek out opportunities for growth on your own, and you know, you don't have to wait for your institution to bring them to you. And if you find something that's really useful, advocate for your institution to support those initiatives. I really do believe that the relationship with institutions and organizations is bidirectional. And so just as an organization has an obligation to support its members, employees, staff for continuous learning and supporting educational aspirations, we can also help highlight areas that need improvement and resources and trainings that we feel will be impactful for our organizations and institutions. Okay. All
Dr.
right.
McFarland,
Yes.
just very quickly, time check of 1:06.
Okay, thank you very much. We are rounding up shortly. Okay,
Excellent.
and so I thank you. I wanted to just briefly demonstrate that much of what we discussed here today aligns with Castle Poe's key principles, and I hope you have seen how they've kind of been woven in through our session today, from the recognition of individual uniqueness and seeing the humanity in everyone, the importance of practicing with cultural humility and an ongoing commitment to further learning, critical reflection with respect to conscious and unconscious bias, and anti-racism and anti-discrimination practices. Next slide, please. So finally, again, Ubuntu, I am because we are. I want to close with this philosophy that I shared earlier. I am because we are, which speaks to our interconnectedness and our collective humanity. After all, think about it. We cannot be human by ourselves, right? So this philosophy applies directly to the work we're doing to dismantle anti-Black racism in healthcare. It pushes us towards a healthcare system that doesn't just treat symptoms, but heals the differences and divisions caused by racism. It also asks us to maybe consider the ways in which anti-Black racism, when allowed to persist, ultimately harms all of us as a society. So in our collective commitment to dismantle anti-Black racism, I want a moment to maybe say this together. Now, I know that I cannot hear you audibly through this webinar system, but I think there's great power in doing this together. And so if you all will say this in wherever space you're in, following this cadence, Ubuntu, I am because we are. Again, Ubuntu,
Ubuntu,
I
I
am
am because we are.
And one last time, Ubuntu,
Ubuntu,
I
I am because
because we
we
are.
are.
Wow. Oh, thank you for unmuting. I just think it's so powerful when we do that together, and just really shows our commitment to this work. And so dismantling anti-Black racism is a collective responsibility, and the seeds we've sown today will hopefully grow into the eradication of anti-Black racism in the future. Thank you. Thank you. The next few slides are just some of the references. I wanted to highlight the Black Health Education Collaborative. They have developed a primer on anti-Black racism in healthcare, so they provide a series of modules to delve deeper. I do not have a conflicting relationship with them other than I'm a supporter of this work and I'm engaged in a community of support for School of Medicine Black health leads like myself. So encourage you to check that out. So, and I think there's a slide there with my contact information. So I'm happy to address any questions that folks may have. Thank you.
There is, thank you so much for that, Dr. McFarland. That gave me chills, I will say, saying it with you. So I appreciate and I thank you for sharing that with us. Before I move into very brief questions, I just want to make a comment that today's video, as we mentioned earlier, will be posted. The recording or the video that was in today's presentation will also be available for any of you who want to go back and look at it again. So I just want to start out just kind of very, it seems like a simple question, but I think there's a lot to unpack. I've heard the conversation around people saying, I'm colorblind. I don't see color. And so I was wondering what your thoughts are on really why is that maybe not the most responsive or realistic way to approach that type of conversation.
Thank you, Priya, for that question, or whoever posed that question. And it's one that comes up quite frequently. And I will say, you know, I see the heart of that statement, right? But I think something to kind of keep in mind with some of this work is understanding intention and impact. And what impact? The impact on those individuals. And we have to listen to how that resonates or how that makes Black people feel. And so I will say, I'm blind to color. Is an effort to demonstrate that I am not treating you different based on the color of your skin. However, my race, the color of my skin, really impacts my experience in life, right? And it's almost like saying you don't see me, or you don't recognize or appreciate perhaps some of the unique factors that impact my day-to-day life and my experiences. And so even if we applied this idea of I do not see color or I'm color blind, how then can we have these conversations? How then do we identify and unfold some of the negative impacts that Black individuals are experiencing? How then do we learn to create interventions or uh, tailored care so that it's culturally appropriate and affirming for folks? So I think it's just moving away from what makes me feel comfortable as the individual, maybe saying I don't see color, and maybe kind of stepping back and saying, you know what, I am anti-racist. And I am careful not to make the color of your skin or your race impact how I interact with you. But I understand that the spaces in which you work, live, and play, your race plays a huge factor, and being sensitive to that.
Apologies, I lost my mute button there. Thank you. I think that that helps, and you know, the conversation not around blaming, but around recognizing that, you know, it does make a difference. The way you're treated in society, skin color does not scientifically make a difference, but the way,
Right.
unfortunately, we treat each other, that's where the differences come from. And I just have a comment. I am going to paraphrase it, but I thought it would be helpful to share that it's important to understand the historical the historical context and understanding of Black culture as its investment in Canadian society, and where that has in some places been placed in less value or less important because of this divide as to who is believed to be Canadian as opposed to who is new to Canada. And if I have summarized that in an incorrect way, I do apologize, but thank you for the feedback. And those of you who saw me earlier, I can now see the questions. One question I want to raise, and it's sometimes a bit difficult, I think, when you're working with colleagues or friends, and you touched on this earlier in the presentation, but how can you, or what I guess is some suggestions that you might have for individuals who want to speak to their colleagues or their friends about their anti-Black racist beliefs, and where, you know, they may not think that they're being a racist in that category or want to be labeled with that because it's very antagonistic, but how do you manage those conversations?
Yeah, you know, great question. And very much like this talk, I don't know that I have all the answers today, but I think with anything, it comes down to communication. And I think I touched on respectful curiosity. And so really, you know, not always just blurting out, you know, questions and things you want to know, but really interrogating, why do I want to know, and how does that add value to this conversation or this relationship, and communicate that, right? And so sometimes people ask because they want to form connection. And there are many different ways to form connection, but you can also preamble, you know, either I've had such an experience and I've wondered if you've had similar experiences. Another part of your question was, you know, how do you communicate maybe some of the anti-Black racist ideologies that one may have. And I think it's not the responsibility of that Black individual of an organization or your Black friend to necessarily educate you on that. And so it goes back to seeking out that education. We have a lot of tools and resources nowadays for which you can learn more, delve deeper into the details of some of these things. And chances are the idea is that you have came from somewhere, right? And so there's likely a reason for that, and doing the learning, the changing, and of course, in spaces like this and others, bring those questions, do the work, talk about the challenges you have, and buddy up with others who seem to be doing well in this area as well, like your colleagues. It doesn't necessarily have to be a Black person. It can be a Black person, but talking with each other, I think it comes down to communication, compassion, seeing the humanity in each other, and working together at this.
I think that was beautifully said. I don't think you give yourself enough credit there. I want to thank you. We are at time, but I want to thank you genuinely for the work that you do in supporting patients and receiving appropriate and responsive care, and for sharing your insights and your experiences with us this afternoon. As mentioned earlier, today's recording will be available on Castle Coast website, and we will be offering more sessions in the series, so please monitor your emails as they come in. We want to thank you for joining us today, and we hope everyone has a wonderful afternoon. Thank you so much.
Thank you, everyone. Take care.